This week's topic is pain management. Let's look at a few pain management drugs, but first we're going to talk about a few little things. I say little, but they're important. So in the pre-hospital setting, us as paramedics, we are allowed to administer controlled substances without a written physician order. To my knowledge, we're the only healthcare providers that are allowed to do that. Nurses and things need written orders in most situations in order to give things like this. So I say that to say this: there's an enormous amount of trust put in us to make good decisions when we are administering these medications. There's also the potential for liability in administering these medications, and so we have to make sure that everything is done exactly right. Administering a controlled substance to a patient is a big deal. Having access to controlled substances is a big deal. Each EMS system is going to manage their controlled substances in a different way maybe, but it's all fairly similar. Typically, first thing in the morning or even whenever it is that you do your shift change, when you come on shift, you are going to take responsibility for those drugs, and that has to be documented. And that may be on a computer system like we use in Onslow County, or it may be just in a book that's written down. That's what I did everywhere I've ever worked before I came to Onslow County. But some way or another, the responsibility of those medications will be transferred from one provider to another as you do shift change. In North Carolina, the drugs are supposed to be locked behind two locks. How systems go about doing that is subjective. I've seen it done really well. I've also seen it rigged to where it is not really that secure. But that's beside the point. What I'm getting at is it's a big deal for you to have the responsibility of these medications. It's a big deal for you to have the ability to have access and to administer these medications. Be super careful with these medications in storing them, and make sure that when you do your shift change, you verify that all the meds are there. One of these meds magically goes missing, and it could possibly be traced back to you even if you had nothing to do with it, because there was a little glitch in your paperwork for the chain of custody, I guess we'll call it. That could be a big deal. That could mean you lose your job. That could mean you lose your certification. In some cases, that could mean you go to jail. So it is very important to keep good records of these drugs and make sure that you're doing the things that you need to when they are in your possession. So right down to the dirty here. Let's start off with morphine. Morphine is an opioid, similar, the same as heroin. It stimulates mu receptors, MU, but we'll call them opioid receptors. It is a Schedule II narcotic. Morphine is going to be your generic name. Roxanol, MS Cotton, those are going to be your trade names. We know a little bit about morphine already. We do know that morphine also can, or you should know that morphine can decrease preload, which means it's a vasodilator. And we used to use morphine quite frequently for ischemic cardiac chest pain and for congestive heart failure, pulmonary edema patients, because it does do a good job at reducing preload. But currently, in our protocol in North Carolina, we only use it for pain management. Sorry. All right. Sorry about that. Had a little bit of an interruption. Try to pick back up where we left off. I believe we were talking about how morphine also acts as a preload reducer and is used in treatment of pulmonary edema and heart attacks. So first, morphine. How do we decide when we can give pain medications? Let's go to that real quick. I don't think I talked about that. So it is up to you as the provider to make a determination of who gets pain medications and what pain medications that they are going to get. And that's how it is in most systems. Some systems may constrain you a little bit more and only give the option of one or two different things, but most systems you carry multiple different pain management medications. So it is up to you. Your indication for morphine would be moderate to severe pain. Everybody's going to be a little bit different. You'll pick people up that have stubbed their toe and they say that they're a 12 out of 10 pain. I'm not saying they don't hurt, and I'm not saying that they're full of baloney. You have to make that determination of who's going to get pain management, who is not. Anyway, moderate to severe pain. So contraindications, as always, hypersensitivity. Anybody with a depressed respiratory drive, why would that be? Well, that's because this is an opioid, and we know that opioids slow the breathing rate. Excuse me. Because it dilates blood vessels, we want to be really cautious and probably not give it in patients who are even remotely hypotensive, because it's going to bring the blood pressure down even more. All right. just cruising through the main things here. Your dose for an adult is going to be 4 milligrams, and this 4 milligrams should not be a fast push, and we want to dilute that typically with saline. You don't have to, but it's just a thought. Sometimes pain management medications, especially your opioids, will hit somebody like a wrecking ball. You push it, and all of a sudden they're supine on the bed, staring off into space, talking to Jesus or something. But anyway, we can mix this in a 10 ml syringe with saline and give it, or you can give it just as 4 milligrams, but make sure that we give it slowly, no matter what, over a minute or so. And then we're going to flush behind that with a 10 ml flush. So we can give 4 milligrams and then an additional 2 milligrams every 5 to 10 minutes. Your max dose is going to be 10 milligrams. And we're going to do this either until clinical improvement or until we reach that maximum dose. And again, we can give 4 milligrams initially and then another 2 milligrams every 5 to 10 minutes. We're not worried about pediatrics right now, and this is a pregnancy category C. May drop the blood pressure, may cause respiratory depression. All right, our next drug is fentanyl. So fentanyl is also an opioid, but the biggest difference between morphine and fentanyl is that fentanyl is a synthetic opioid analgesic. It's a synthetic narcotic, which means it is not derived from poppy plant. So fentanyl is also much, much more potent than morphine is. And fentanyl is measured in micrograms. We'll see that down here in a minute. Here we go. And another thing to note is 100 micrograms of fentanyl is equal to about 10 milligrams of morphine. So 100 mics is equal to about 10 milligrams of morphine. Our starting dose sometimes is 100 mics of fentanyl. I gave a guy 100 mics of fentanyl yesterday because he had a broken leg. He had wrecked a motorcycle. So that's equivalent to about 10 milligrams of morphine. Typically, fentanyl does not have the significant respiratory depression and the significant hypotension that can be found with morphine because it is a synthetic opioid agonist. It's engineered a little bit differently to where it doesn't have as many of those side effects. It can still cause respiratory depression and can still cause hypotension. So keep that in mind. It acts on the same receptors. It acts in the same way as morphine does. Your contraindications and your indications are the same as for morphine. A side effect, though, that we need to keep in mind that is specific to fentanyl is skeletal and thoracic muscular rigidity. So if you have a patient who has issues with muscles in their chest wall, they have different diseases which causes chest wall rigidity already, this can make them worse. So just keep that in mind. All right, our dose. Now this dose is kind of subjective and they keep changing it around. Currently, it's 50 to 75 micrograms IM, IO, or IV, or we can do IN. So IM, IO, IV, or IN. Repeat 25 mics every 20 minutes with a max dose of 200 micrograms. Check your local protocol for this because this could be a little bit different. And also it keeps flip-flopping of what they want. At one point it was 1 mic per kg. Now it's 50 to 100. So just whatever your local protocol says, go with that. But this is kind of a standard dose for fentanyl. All right. And what drug do we have that could reverse the effects of morphine and or fentanyl if I was to give a little bit too much? Narcan, absolutely. 0.4 to 2 milligrams is your IV dose of Narcan. All right, the next drug on the list, actually, let's bypass this. Let's go down and look at Dilaudid. There we go, Dilaudid. The reason I'm bypassing those, we will come back to them, but that's because Dilaudid is also an opioid. Let's go ahead and knock out all the opioids before we do anything else. So Dilaudid is the trade name. Hydromorphone is the generic name. It's also a Schedule II. It's an opioid. It works in the same way as your other opioids do. It is much more potent than morphine as well. It doesn't say down here. I used to give this a decent amount in the ER when I worked in the ER, and on the label it had a red label, and on the label it said caution, this drug is 7 times more potent than morphine. So it is a pretty strong drug. Indications, contraindications are essentially the same. All right, your dosage and route. Again, kind of subjective. This is a standard dose. Excuse me. A half to 1 milligram IV bolus. And this definitely is a drug that you're going to want to mix with a 10 ml saline flush when you give. This will knock somebody square on their rear end if you don't do that. So mix this with a 10 ml flush. 0.5 to 1 milligram, and then may repeat in about 20 minutes. Max of 2 milligrams in most situations. Pregnancy category C. Again, have Narcan available. All right, let's scroll back up. Ketorolac, or Toradol, as it's more commonly known as. Toradol is thought of a joke sometimes when people talk about pain management drugs, but Toradol is actually a pretty potent drug, and it works really well for certain things. Toradol works really well for kidney stones. Toradol works well in a concoction they kind of make in the ER for headaches, or migraine headaches, and a few other things. But Toradol in general is a very legitimate pain medication, but it is not an opioid. Instead, it's an NSAID. So it's similar to that of ibuprofen, but this is given either IV or given IM. Contraindications: hypersensitivity, always. Allergies to other NSAIDs. They have bleeding disorders, renal failure because the NSAIDs are hard on the kidneys. Ulcer diseases, again, NSAIDs can cause gastric ulcers. We'll scroll on down here. Again, we're hitting the big things. Dosage and route: if we're giving this intramuscular, then we're going to give 60 milligrams IM. 60 milligrams IM. If it's IV, it's going to be 30 milligrams. 30 milligrams. So 60 milligrams IM, 30 milligrams IV. It's also pregnancy category C. All right. Now, a drug that I have actually never gotten to administer, there's only one system that I know of that even carries it. I don't know if they still do or not, but Spartanburg County, South Carolina, used to carry nitrous oxide at least. And nitrous oxide is laughing gas. It's happy gas. The cool thing about nitrous oxide is you can't really overdose on it. It works really well, and it can be self-administered. So this comes in a mask. It hooks up to a bottle similar to that of an oxygen bottle. It is an inhaled pain management medication, but it's not really a pain management per se. It's more of a I don't care what's going on anymore drug. So it's not necessarily an analgesic, but it makes you not care about what's going on. Excuse me. It can cause hypotension. Keep that in mind. It can cause respiratory depression. Keep that in mind. Your dosage is 20 to 50% concentration mixed with oxygen. I've never seen it used. They use it sometimes in dentist offices and things. Alright. Last but not least, Tylenol. You should already know everything there is to know about Tylenol because it is a EMT level drug. So we're going to skip through most everything. Adult, 15 mg per kg, max of 1,000. 15 mg per kg, max of 1,000 for adults. Alright, those are your pain management drugs. Let me know if you have any questions.